Good evening, everybody, and welcome to Adults and Health Scrutiny Committee on this Tuesday, the 13th of July 2021. Can we have item agenda number 1, apologies for absence?
Thank you, Chair. We have apologies for absence from Councillor Ali, and Councillor Iqbal is in attendance as substitute, and also Councillor Knight has sent her apologies. Thank you.
Thank you, Paulina. Welcome, Councillor Iqbal. Agenda item number 2, declaration of interest and whipping declarations.
I work for North West Anglia Foundation Trust, so if anything comes to scrutiny from the Trust, I will declare an interest. Thank you.
Thank you, Councillor. I think that's all. Agenda item number 3, minutes of the Health Scrutiny Committee meeting held on the 15th of March 2021. Obviously I wasn't there, so if there are people who were here, if they can tell me whether or not it was a true and accurate record of what happened on that night, and they want the minutes to be approved, then please let me know. Perfect. Can I have do I need a proposer and a seconder?
Yeah, that's fine.
Okay.
Yeah.
Okay. Apparently, I need to mention, if we have a fire, then the evacuation process is that you run like hell through that door, and we meet in the square out there. Item number 4, call-in of any cabinet or cabinet member or key officer decisions.
Thank you, Chair. We have no call-ins for this evening's meeting.
Thank you, Paulina. Agenda item number 5, appointment of co-opted members.
Thank you, Chair. This is a standing report which comes to the committee at the beginning of each municipal year. Each scrutiny committee can co-opt up to 4 independent co-opted members, one of which would need to be, at least one of which would need to be a parish councillor representing rural communities, representing parishes. The nominations that come forward for this position are presented to us from the Parish Council Liaison Committee. So for the report this evening, we have 2 possible positions that can be taken. One is for Parish Councillor June Ball, who has been on the former Health Scrutiny Committee for a few years now. And also we have a new nomination, which is Parish Councillor Neil Boyce. And Parish Councillor Neil Boyce used to be, and possibly still is, a co-opted member on the Community Scrutiny Committee. The committee this year have taken on some new responsibilities, which is adult social care, and Councillor Boyce is quite active and interested in that area of service. So he has put his name forward as a potential second substantive co-optive member for this committee. So it's for the committee to decide whether you are happy to accept those nominations. Thank you.
Thank you, Pauline. So do we do them both together, or does anybody have any objections to either candidate? If so, if not, then we can do it all as one and move on. Agreed. Agreed. Welcome, councillors. Do you want to come and take your seats? Councillor Barkham.
Thank you. Just briefly. So 2 members now filled parish councils. So 2 remaining potentials Any criteria attached to those two remaining potentials?
Thank you, Councillor Barkham. No, you would be looking for a skill set that you're perhaps lacking on this committee, that you might feel there's some expertise, somebody could bring some expertise to assist you with the areas of, that you're looking at within the remit of this committee. So there are 2 vacancies, if there are any suggestions. Thank you.
Thank you, Paulina. Agenda item number 6, which is for the committee to note the report managing COVID-19 public health update. Thank you. For the benefit of the committee and for the record, the report is going to be delivered by Emmeline Watkins, Deputy Director of Public Health, and we're joined with Jo Teatri, who is the new Director of Public Health virtually. So I can see her, but I don't know if everybody else can.
There we go. Thank you, Chair. I'll take the report as read. However, with COVID-19, the numbers are permanently changing. So what I do want to give you is the up-to-date figures for the COVID-19 case rates in Peterborough at the moment. So we are seeing an increase compared to what was reported in paragraph 4.2. So Peterborough currently has a case rate of 153 per 100,000 for the week up to the 7th of July. That's for all ages. Now that is actually lower than both the East of England average, which is at 215 per 100,000, and also less than half the England average, which is 318 per 100,000. So although we have increased since the end of May, we are actually still below the East of England and England average. You will have seen in the news and with all of the announcements coming, we are expecting to see case rates to continue to rise as restrictions ease. The hope is that the vaccination levels are going to be sufficient to keep hospitalisations low. Hospitalisations currently, they've fluctuated very slightly, sort of between about 8 and 15 across Cambridgeshire and Peterborough, and currently for the data for the North West Anglia Foundation Trust up to the 6th, I think they had 4 people in hospital. So hospitalisations for Peterborough residents do still remain low, but we are coming up to easing of further restrictions, expectations that cases will rise in Peterborough along the lines of what we'll see in other areas in the country, and a summer where we'll have a lot of cases, but the hope that the outcomes will remain improved. However, the modelling does anticipate that we will see an increase in hospitalisations over the August-September period of time. In terms of mortality, there isn't actually an update on the numbers that were provided there. There haven't been any deaths, additional deaths, either within 28 days of a positive test or as COVID-19 on the death certificate, so those numbers still remain current. In terms of Delta transmission, the expectation is really now that most cases across the country are Delta. We still do get occasional cases of other variants, but currently the expectation in Peterborough is that all the cases are Delta. I think that's the main updates to the figures from the papers, so I'm happy to take any questions.
Thank you, Emmeline. I've got Councillor Graham.
Thank you, Chair. Thank you very much, Dr. Watkins, for giving us that brief overview. The concern is that in view of restrictions easing towards the end of summer entering inevitably into the flu outbreak season, do we have an emergency plan in place to negotiate potential increase in admissions to ease off pressure from the local trust? And do we have any details, a separate question, do we have any details on the number of vaccinated individuals that have been infected with COVID-19? Thank you.
So on the winter planning, there are winter planning local resilience plans which are done through the local health LHRP resilience planning group, and that does pick up the sort of pressures over winter. However, I do agree that with flu and COVID, we've got to have real sort of making sure that the plans come together. So if we're dealing with an outbreak, we're dealing with it in a sort of coordinated manner, because it will be a respiratory outbreak and we might not know whether it's a flu or a COVID outbreak at that point. So what we're doing at the moment is going through both the COVID plans and processes and also the outbreak management plans for flu to make sure that those processes are in place ready for autumn. Jyoti, I don't know if there's anything you want to add to that.
No, I agree that it's a worry, and I think the timing of lifting restrictions was always going to be a difficult decision. And had it have been later, we would have been even further into the winter period when a spike is inevitable. If we're going to lift restrictions at any point, a spike is inevitable. And I think this was a question of when's the best time to have that spike. And I think lifting of restrictions now brings the spike a bit earlier and not in the peak of the winter.
And picking up on the second question of do we get positive cases in those who've had a double vaccination? Yes, you do. So the PHE data, which is collected nationally and is much more reliable, shows that especially against the Delta variant, 1 dose is less successful, but 2 doses for symptomatic disease, you are still going to get some symptomatic disease. On the other hand, the levels of protection against hospitalisation for the Delta variant of the current vaccines looks to be very good, but exactly how good that is, they're still refining the confidence intervals around that true efficacy that we're seeing in the real world. So yes, we do see cases, and we will see cases in hospital who have had a double vaccine because the vaccine isn't 100% effective.
Thank you. Thank you for your hard work as well.
Councillor Bull.
Thank you, Mr. Chairman. The city has a very low vaccination take-up rate, and I'd like to understand the causes and reasons. For example, Peterborough has over 10% less take-up for those with 1 dose and nearly 12% less for both doses than the rest of the country. And this is concerning on 3 counts, I think. The Delta variant being very much more transmissible, and the step 4 going ahead, as you mentioned, on the 19th of this month, and the possible loss of confidence in the Oxford AstraZeneca, especially amongst the young people. And I think this might have something to do with other countries like France not giving the Oxford AstraZeneca to anyone under 55, Denmark not giving it at all, Italy not giving it at all. And I think we've had in this country something like 300 people have blood clots and bleeding on the brain directly attributable to that particular vaccine, of which I think 57 have died. And I speak with some authority on that, as my extended family currently have 1 person dead because of that, and 1 person in neuro intensive care with bleeding on the brain at the Queen Elizabeth, Birmingham, specifically due to the Oxford AstraZeneca. So I can understand that there is some concern around that 3rd arm that I mentioned, but I'm just wondering, why is take-up so very much low in this city compared to the national figures? Thank you.
So I agree that the vaccination uptake in Peterborough is something that we really need to continue working on. So the clinical commissioning group do deliver the vaccination service, but as a city council and a public health team, we've been working with them around the community engagement, around issues trying to understand where to put sites, but also the engagement on the ground, which is absolutely critical. So you're absolutely right. Currently, vaccination first dose is at about 67%, and second dose is at about 47%. We have areas that are low in the centre of Peterborough, and we have age groups that are low, both in the 50 plus, so those more at risk, and in the younger age groups. And so actually the drop that we see is across all age groups, and some of those aren't AstraZeneca. You know, the younger age groups don't get offered the AstraZeneca. So the information on the ground is that, yes, side effects do come up as a concern, but not necessarily always specifically to a particular vaccine. And you can unfortunately see that the uptake in our younger age groups is also below where we would want them to be. So I think there's a lot of different reasons, and there's a vaccine confidence group that has membership from the CCG, Public Health, from Peterborough City Council, from all of the district councils, who then engage with the community groups to try and get the information on the ground, understand the issues, understand any issues around vaccine confidence, that we can try and address those, because it is going to be key for us to sort of get over the autumn successfully, to have a good vaccination rate.
Ask a supplementary, Mr. Chairman. So that vaccine confidence that you're talking about, how are community groups and the new vaccine confidence group, what are they finding in terms of resistance to people across the board, it would seem, not wanting to be vaccinated? I just wonder what those rationale, what the rationale is behind it, if there's any sort of main theme that can be combated or countered. Thank you.
So I think there's a lot of different themes that come through from different groups. So access is one, actual confidence, so issues for young people either with side effects or fertility, pregnancy. There's a variety of issues that come up, but people are worried that they won't be able to work if they do get side effects. So there isn't one. I would love it if there were one answer. And Jyoti, do you want to come in? I can see your...
I was just going to say, this is something that we're trying to investigate further. So we've commissioned some behavioural insights work, particularly with young people, because we know uptake could be lower, and because there's a perception that they're at lower risk and maybe less, therefore, inclined to take up the vaccine. But we want to understand that a bit better. So we've asked for some behavioural insights work to happen with young people, and also with some over 50s groups as well. So we'll know more when that comes through.
And community groups such as Gladco, Youth Inspire are the ones who are actually engaging on the ground, and we do have people engaging on the ground and knocking on doors and asking about it. So there's a huge amount of work that the teams in Peterborough City Council have been doing to try and get underneath some of this issue.
Thank you.
Thank you. Councillor Barkham.
Thank you, Chair. Page 22, section 9.2, the Coronavirus Act 2020. What are the new legal powers that are being granted?
So part of that's the contained framework, which is the ability to shut down an event or a business for a particular reason. That's actually sort of changing at the moment. So with the release of step 4 of the roadmap, the framework will be in place, it looks like, until the 28th of September, but anything that you want to do has to A, be at risk, increasing risk of transmission of COVID-19, be proportionate and appropriate. So we have used direction notices across in Cambridgeshire and Peterborough for particular events, for example. But I think going forward with the release of the restrictions, so actually this was written, of course, before step 4 came through, and actually the legislation is changing so that a lot of the things are not in the legislation at the moment. However, the contained framework and the ability to have a direction notice looks to be that currently it looks as though it will be possible for until September the 28th, but actually when you would be able to put that into place would have to be a sort of an exceptional circumstance, so probably not the increase in cases that we're expecting.
Thank you.
Councillor Cohen. Oh, I didn't see you, sorry.
Hi. Is there any plans for any other vaccination centres across the city instead of residents having, those that are on low wages having to take two bus rides into the city care centre? And also, how are we going to encourage the uptake on vaccinations as it is very low in Peterborough and especially our young population? Thank you.
So the CCG, I would recommend that people look at the vaccinators.co.uk because that's going to be the most live site with the clinics coming up. So currently Boots in Queensgate is one of the sites, but they are looking and doing the clinical verification for an additional 5 sites that are across this and much more centrally focused to make it easier for people to get to for precisely that reason. So people don't have to go either to the East of England showground. So the one that's currently up and running is Boots Queensgate. And that's a walk-in that is open, for example, on the 15th from 8 till 4. But the vaccinators website, and I can send that round, is where the CCG put the most recent and up-to-date information. So it is definitely the one. It also gives the permanent sites. It's their sort of full summary of vaccine sites. So the Vaccine Confidence Group and the Rapid Response Team have been inputting into the CCG of what sites they think would be really valuable in the city centre, and those are going through the sort of clinical processes this week with the hope that they can open shortly.
I looked at that site today, and the 2 sites that I saw in Peterborough was the 3 sites, City Care Centre, the Showground and Boots. But my issue is that actually we need to be getting these vaccination sites to across the whole of Peterborough, because Peterborough is becoming a large city, so not just so that we've got the population coming into the centre. It just seems it's very Peterborough centre for vaccinations. You've got Boots in Queensgate and you've got City Care Centre just over the bridge, and then of course the other side of the city you've got the showground. We really do need to get these vaccination centres set up across the whole of Peterborough.
Yeah, so I can feed that back to the CCG, but as I said, they are looking at 5 sites at the moment, which are broader, but they are centrally focused because that's also where our lowest vaccination uptake, and so we have prioritised the areas that are lowest and also those that are lowest, especially for the 50-plus groups, because they're the most clinically vulnerable group, and even getting them 1 vaccination will protect against hospitalisations.
Question was, how are you encouraging the young people to come and get their vaccinations?
So again, this is with the CCG and the Vaccine Confidence Group, and it's a lot of different initiatives. So Youth Inspire is working with the slightly sort of beyond school age group. Things like the Posh walk-in clinic did get a young age group through, and hopefully the availability of the other walk-in clinics, but it's again one of the areas is that slightly slower uptake in the young groups. So there's something about getting the message out there, increasing the walk-in availability, which is the CCG's delivery, and getting the engagement on the ground as to what are the issues that people are not going and getting the vaccine.
Thank you. I think, Jyoti, did you have your hand up? Did you want to come in? Or?
Emmeline's covered it adequately, I think. Thank
Councillor
you.
Cohen.
Thank you, Chair. It's emerged that offshore we're seeing increasing cases of a new Lambda variant, which is supposed to be relatively more aggressive. My question is, has this emerged here within the UK, seeing that there aren't any restrictions? It's come from Canada. And if so, what's the risk to Peterborough? I know it's a bit of an off-shot question, my apologies, but should this be a variant of concern at this moment in time, or is it under sort of scrutiny? Thank you.
Shall I repeat that, Emily?
Yeah, do you want to take that?
Yeah, we had a meeting with the Chief Medical Officer a couple of weeks ago, and he mentioned a number of variants that were under investigation, including the Lambda, and he wasn't overly concerned at the moment that it was a particular risk in the UK.
That's fabulous, thank you.
And just on the Peterborough side, we do get the information on the variants that come in. There is a lag to that, so whole genome sequencing, especially with the sort of capacity push at the moment on testing, still does take a bit of time to come through, but we then do track which variants we have through in Peterborough and in Cambridgeshire.
Thank you.
Councillor Rush.
Thank you, Chair. Is there any data to show what age groups are fueling the rise in new cases?
Yes, we do get age information for all of our cases, and so what you will find at the moment is the highest rates are in the sort of 10 to 25-year-olds, so school age, secondary school age, and young people. However, what I would say is, unlike some of the other areas across Cambridgeshire and Peterborough, the distribution of cases across ages in Peterborough is pretty general. We have cases across all age groups, across all ethnicities and in all areas, and there aren't sort of particular spikes where we're able to target and say, can we do a huge amount of testing in that particular group at the moment. It is a more diffuse picture in Peterborough than we have in some of our other areas.
Thank you. Councillor Farouk.
Thank you, Chair, and thank you, Dr. Watkins. Looking slightly forward, my question is sort of based around sort of self-isolation of those who have been fully vaccinated. Obviously, once we achieve a much higher percentage of the general population fully vaccinated, I know based on national legislation, which I believe starts on August the 16th, hospital trusts at their discretion will be able to make self-isolation for staff sort of a suggestion rather than an obligation. Can we see this sort of being open to the general public as well at some stage? And if so, will this be, again, based on national legislation, or will it be sort of local public health boards able to make that?
So this will be national. So on August the 16th, according to the summer roadmap, the plan is that contacts of cases, if they are double vaccinated, won't have to self-isolate. So by August the 16th, there will be certain groups that won't yet have had their double vaccination. So some of the younger groups are probably not going to be all double vaccinated by that point. So it will be available to some but not others. In terms of cases, there are pilots that are ongoing, which are the cases, my mind's going blank, cases will have to self-isolate. There are also tests to release for other sort of pilots that have happened. But at the moment, it's a double vaccination that's available to contacts from August the 16th onwards.
Councillor Warren.
Thank you, Chair. As we're seeing an increase in COVID cases in school children, what is the vaccination plans for children at school, and what actual vaccination will they be using?
So that's a decision that the Joint Committee for Vaccination and Immunisations are reviewing at the moment, which is looking at the risk benefits for children, because as you've discussed this evening, there are risks to vaccination, and children actually don't see that many risks in terms of COVID when they catch it. So the JCVI will need to come to a recommendation that then gets fed on to NHS England, who will put the clinical procedures in place. So at the moment, there isn't any guidance on whether under 18s, apart from those who are clinically vulnerable, would get vaccinated.
Councillor Burbidge.
Thank you, Chair. Is there any information on whether there's going to be the need for a third or a booster jab or a more regular jab going forward like the flu jab is now? And do we have anything in mind for providing that if it does?
Yeah, so there is planning in place for a third booster. I think the clinical trials are still ongoing as to finalise to who gets that, but the planning is already in place to provide a booster vaccination. And as far as I'm aware, that's likely to be in conjunction with COVID, but with flu vaccination. But again, it's finalising that clinical detail. So Jyoti, I don't know if there's any other update on that.
No, that's right. I think you've covered it. Yeah.
Thank you. Councillor Bull.
Thank you, Mr. Chairman. Can I just turn to a slightly different tack and ask how many long COVID cases there are in the city impacting on our health and hospital services presently? Do we have that data?
So the CCG and Healthcare have set up a long COVID clinic. I don't know the numbers that are going to it at the moment, but I can ask for the information for you. However, I don't think that would be a good estimate of those who potentially are suffering the effects of long COVID at the moment, because we don't really understand all of the symptoms that are captured by long COVID and their impacts. So I think that's a piece of work that's sort of being done nationally, and it looks like for a lot of people that it does take a long time, but there's recovery unless there's sort of been damage to the particular organs. So I think that's emerging, and it's not a piece of information that I have for Peterborough.
Thank you. Councillor Farouk.
Thank you, Chair. Just to follow up in terms of the booster vaccine, I know there's some research come out saying in terms of mixing vaccines that it, in fact, can prove to be even more beneficial. So going forward, do we anticipate that this will sort of become a non-talked about issue, and it will sort of be any vaccine can be offered, or will it sort of be in conjunction with what people have previously had?
So the clinical trials are ongoing around mixing the vaccines, so there's a balance of do you get improved immunity versus what's the side effect profile, so that evidence is still emerging. JCVI, again, will make the decisions as to what is the national programme, but given that COVID is becoming it's still in its epidemic and pandemic phase, but it will become endemic. I would anticipate, and it will still have variants emerging, that we will need new vaccines again. I would anticipate this is a long-term thing that we're looking at.
Thank you. I believe that's all the questions. So it's now down to the committee whether we note the content of this report, or whether or not we have anything that we would like further information to come back to the committee on, or whether we want to make any kind of recommendation. Do I take it that everyone's happy to note the report on that case? Okay, thank you very much. Agenda item number 7, which is Cambridgeshire and Peterborough Adult Social Care Partnership Board's 2020 and 2021 annual report. And I believe, Charlotte, you're delivering this.
I am, yes. Thank you very much, Chair, and thank you to the committee for accommodating a virtual input from me. Debbie McQuaid is also with you in the room, and she's one of our assistant directors for Peterborough, and will be able to support any discussion and answer any questions. So I'll just introduce this very briefly, assume that you've read the report. So the purpose of the report really is to give the committee an overview of the partnership boards which have been established across Cambridgeshire and Peterborough for adult social care. And the role of these partnership boards really is to challenge us, is to give us feedback about our services and areas where we need to improve, and is actually a source for us to go to get views and input on how do we develop adult social care going forward. So it's a very important report. It sets out the rationale for the partnership boards which have been set up in the different client groups and the priorities they've been working on. I think most importantly, the report gives you a sense of the issues that have been raised with us by the partnership boards and the changes that we've made as a result. And so really we're very happy to answer any questions and provide any feedback about any issues that the committee is interested in.
Thank you, Charlotte. Do I have any questions? Councillor Bull?
Thank you, Mr. Chairman. Charlotte, out of interest, who were in the old partnership board setups, please? And what's happened to the Sun network? That's the network that looked at those who use mental health or drug and alcohol services, and also the Counting Every Adult co-production group, which represented adults with multiple issues such as homelessness and the like. I can't see that they've been captured in the new partnership setup, but I could be wrong. Thank you.
I'll answer as much as I'm able to, and ask Debbie just to chip in. So I think the old partnership board for Peterborough had a stronger kind of officer presence. So as you'll see in the report, there's a commitment that at least half those people on the partnership board will be either carers or service users. And Healthwatch have been really helpful in helping us to develop that. Now the Sun Network, I think, feeds into, we have something called an Adult Social Care Forum as well, which covers all client groups, and so they would feed in there. But I think the Sun Network does still exist. It just isn't formally one of our partnership boards, but we do get very involved in the Sun Network, which, for those of you who don't know about it, is a mental health network. Don't know, Debbie, if you want to add anything.
I think you've covered most of it. I think page 29 refers to the other forums that are still up and running, and they do link in quite strongly with the partnership boards. So they are still really relevant and still really very important, and there are those links.
There are several cross-cutting issues. If I may just ask a supplementary, Mr. Chairman, there are several cross-cutting issues here. I mean, mental health affects everyone irrespective of age, disability, whether it's sensory, mental or physical, and also homelessness can affect everyone at any given time. So are we saying that these organisations are still quite highly thought of within the new framework of partnership, and that they do have equal share of say at the table, or why have we actually moved away from them having their own networks and offering up resolutions to them being embedded in the new partnership framework? It's the intriguing part to me. Thank you.
Okay, so they are absolutely just as important, and you're absolutely right. Mental health affects everybody, and there's, not every forum will be mentioned in this paper, but yes, they, and in terms of the partnerships we had before, there was a consultation around what partnerships we would take forward. That was across Cambridgeshire and Peterborough, and that was supported by Healthwatch. So, and this is basically the partnership boards that we, there was a lot of consultation around that. It wasn't a decision that was taken lightly.
Thank you. Councillor Warren.
Thank you, Chair. 4.4.1, NWAFT confirmed that there will be a pilot in a healthcare at home service that would extend the service to patients to attend the ACU to assess the number of patients that might benefit. The pilot was aimed to include patients from Peterborough City Hospital from mid-February to March 2021. What was the outcome of this pilot scheme?
I think we would have to ask North West Anglia Foundation Trust for details on that. I mean, they have, as a result of COVID, made quite a lot of changes to the way in which quite a lot of their services are delivered. So certainly, unless Debbie knows the answer to that detailed question, I'm certainly happy to take that away and make sure that we get an answer for you from North West Anglia Foundation Trust.
Councillor Barkham.
Thank you, Chair. Hi, Debbie. Just briefly on the background, 4.11, where it's an overview stating that both councils believe all citizens have a real voice. Exactly how is that voice heard, and do we listen to it?
Well, I absolutely think we listen to it. That's part of our co-production. And those voices are heard through the representatives at these partnership boards and in, various other forums as well. So obviously, when you say every citizen has got a voice, you can't include everybody in the partnership boards or the other forums that are up and running. But actually, Healthwatch and other organisations within the voluntary sector do an awful lot of consultation with the local communities to ensure that their voices are heard. So we absolutely, we're much better. I wouldn't say we are always where we need to be, but we are much better in terms of co-production. And the reason the partnership boards have been set up in the way that they have is because previously they were very much officer-led partnership boards, and we've moved away from that.
Charlotte.
Yes.
Charlotte wants to come in, and then you can ask another one, Councillor Barkham.
Thank you. If I could just add to that, we also do an annual survey. So we, and this is a report we'll be bringing to the committee, where we contact all the people we support in terms of adult social care, and they give us quite detailed feedback about our services and the way in which we support them. So that will be coming back to the committee as well.
Thank you, Charlotte. Councillor Barkham.
Thank you, Chair. You mentioned consultation. It's been brought up a few times in this committee about public confidence lacking in consultation and their voices not being heard. So what are you doing to raise the profile and legitimacy of consultations so that actually what people do say can make a difference?
I'll just start off and respond to that, and then Debbie will be able to chip in. I think it's a fair challenge. I think, which is part of why we felt it's important the committee saw the partnership board's sort of annual report, because actually this is a much more formalised approach to getting feedback than we've had in place previously. But that doesn't, I think, as councillors have said, doesn't stand on its own. And so actually, the crucial thing, I think, is that we're getting feedback and consulting people sort of all the time, rather than a sort of one-off. You know, the annual survey is a useful window, but actually the way in which we want to work, as Debbie has suggested earlier, is we do want to think about co-production and planning of our services going forward. We will be thinking about how we do that within the Think Communities context within the City Council. But the paper does also set out some areas where we have started to involve not just the people who receive support from adult social care, but actually the local community in thinking about, for example, our day services and the way in which we sort of develop services going forward. And we are also very keen to start developing what we call a more of a place-based approach to adult social care and the way in which we commission and provide it, which will enable local communities to start to shape things much more directly. But I think it's a very fair challenge, and it's something that we will need to keep constantly monitoring and improving our approach to, in my view.
Councillor Rush.
Thank you, Chair. Who determines the makeup of these partnership boards? How are individuals selected, and why, given the reliance upon the private sector for care provision, are they not mentioned as included?
Well, so Health Watch have been asked to help us develop these partnership boards, and they work very closely with all the voluntary sector groups and groups that have been mentioned by members of the committee so far. I think it would be difficult for us to involve the private sector, because the private sector is from the adult social care context, it's a provider of adult social care, and therefore often what the partnership boards will be doing will be feeding back to us their experience of those services, and as part of that we would go back to I mean, it's very rare that a partnership board will raise an issue about a particular independent sector provider, but they may. So actually it would be difficult, I think, but what we do make sure is that if we get direct feedback about any specific organisations, we will make sure that we talk to them about that directly, and they've got a sense of what's going on.
If I may, that doesn't really answer the question, and they have a very valid and valuable contribution to make to adult social care in Peterborough and in Cambridgeshire for that matter, and to not include them when they are the people who are delivering a large proportion of the care for adults in the area, not using their expertise, not using their experience, and not involving them in the planning so that they can contribute and be a critical friend, seems somewhat foolish.
So we have, we do have mechanisms for involving the independent sector. So we have a number of forums that we use in terms of working with care providers. There's also a Care Providers Association for Peterborough. And we are planning to bring a report, as you've requested, Chair, to the next committee about all of that work. So I'm sure we can set that out in more detail about how do we work in partnership with the independent sector, and how does all that work in practice. Very happy to include that.
Thank you. I've got a couple of questions if nobody else has. 4.3.3, bullet point 1, it ends with this feedback was discussed at the Cambridgeshire and Peterborough Community Resilience Group. The question is, what was the outcome of this discussion and what has been taken from it?
I think that's... Sorry, Debbie, are you about to...
No, I was just going to say, can you repeat 4.3? Sorry.
4.3.3, bullet point 1. The last sentence says this feedback was discussed at the Cambridgeshire and Peterborough Community Resilience Group. So the question is, what was the outcome of this discussion and what has been taken from it?
So Debbie may want to answer that just because she oversees sensory services, or maybe she doesn't.
So yes, I do oversee sensory services. And I will make sure that that comes back. I don't know what the outcome of that was. I do apologise.
Okay. Same point, 4.3.3, bullet point 2. The aim was that the feedback gathered would help to inform the Council's recovery plan for both frontline practice and future commissioning, providing suggestions for service changes that the Council should keep doing once the COVID-19 pandemic crisis has passed, and highlighting the benefits of new ways of working. The question is, did you achieve your aim, and if so, how is this evidenced?
Yeah, I think we did. One of the areas where we got some really quite direct feedback and we wanted to know what people's experiences of COVID have been was obviously we had to deliver quite a lot of our services virtually. And so we got a sense of, and we fed this into the way in which we're working going forward, those kind of functions which actually people think can be done virtually, and they can be done by video or video conference or by telephone, but actually those services that people felt couldn't be done remotely. So what we've done is we've taken that feedback and used that to really inform our practice going forward. And so there will be some things we can continue to do virtually, but there will be quite a lot of things that actually people said that they found that, you know, that wasn't ideal and they would prefer to see someone in person. So that's just an example of one of the areas that we've built into the way in which we're working. And that's been used to shape the practice of adult social care staff going forward.
Thank you. Do I have any more questions? Then it falls on the committee to either note the report or to ask for any further information to come back to the committee or to make a recommendation. So Pauline has made a note of the information which we'd like further clarification on. So if nobody else has got anything else, then we'll note the report. Thank you.
Thank you.
So we then move on to agenda item number 8, which is the Adult Social Care Recovery Plan update.
And this will be Caroline Townsend.
Okay. Hello. Hi. Again, I will assume the report is read, but just to sort of draw out some key points in summary. Very much what this report is trying to do is provide a bit of an overview in terms of the impact that COVID has had on adult social care services and how we plan to respond to that going forward, particularly from a strategic perspective in terms of our direction of travel. I think it's quite fair to say that there's much data that's indicating at a national level as well as locally that COVID has really shone a really harsh light on inequalities, and it's also affected the way that people access services as well, particularly the way they access health services or care services, and how that then obviously will have an impact in terms of how they may present and flow through to support for adult social care. That said, what we're actually seeing in terms of adult social care demand is really varying at the moment, and it's very much an emerging picture, which does make it quite difficult to predict and forecast what the future of the demand looks like as we progress through the pandemic and we move into the next stages. However, we are seeing some early trends which are highlighted in this report. I mean, I think it's fair also to say that this has obviously been a very challenging time over the period of the pandemic to date. But that being said, we've tried to take the learning in terms of successes that we have had and the focus that has really been drawn out in terms of the community hubs and the community support that has really strengthened during the COVID pandemic. And I think that's definitely reassured and reasserted that moving towards the Think Communities approach and aligning that much more with our adult social care provision, how we do that at a local neighbourhood level and how we work in partnership with those local neighbourhoods and with other services to offer a more holistic neighbourhood level place-based approach to social care is very much strategically our direction of travel. I think just a couple of bits and pieces that I just wanted to highlight as well. Certainly you'll see from the report that our Adults Positive Challenge, which has obviously been a very big part of our transformation programme for adult services over the last couple of years, continues to embed, but there is much more alignment now in terms of our priorities going forward with Think Communities, and there's a number of key areas where we have joint delivery plans in place. And also how we continue to work with providers, how we continue to work with the market, because we recognise that they have been hugely hit by the pandemic and are still facing a number of challenges. That's not to say that we have all the answers, and we do recognise that it is still challenging times ahead. Not only does the predicting of what some of that demand will look like for services remain an ongoing piece that we have to continually monitor and adapt to, but we also recognise that we have to work as a wider system, and how we link in with the development of integrated care system development, which was set out in expectations from the White Paper, is obviously a real opportunity for us in terms of aligning with our place-based and neighbourhood approach. But obviously there is a large piece of work around how that evolves over the coming months. Yeah, I think probably just take questions.
Thank you. I have Councillor Barkham.
Thank you, Chair. Hi.
Hi.
Section 4.1.4, with regards to the inequalities that you mentioned.
Yeah.
Two-part really then. So, what are the factors that have been taken into account with regards to the deprivation, and what's been how are you dealing with the issues of inequality, please?
Sorry, I'm just trying to find 4.1.4.
Page 32.
Yeah, I'm getting there. Okay. So I think what we recognise is, so we recognise that we need to very much adapt services to provision locally. So what we have started to see, so one example in mental health, for instance, is that we have actually started to see an increase in mental health assessments coming through. We've also started to see some trends around, in terms of those accessing adult social care provision. We've had higher rates of over 65s entering residential care in the last 6 months of 1920 compared to the previous time, and we're also starting to see a shift in terms of increased demand coming through for younger people, so working age people that are requiring support. I think for us this is very much around this is where the local neighbourhood and the place-based approach is so crucial, because actually the needs of those local neighbourhoods will shift and will be determined very much by those local populations, and actually waiting for people to come through the door of adult social care, we've missed all those opportunities up front. So I suppose if I just give a couple of examples of particularly where we have done some work very closely with the community hubs during the pandemic. We did some really focused work with carers, because we recognised that carers were going to be a particular pressure, and there were also some both health and mental health issues around carers and the extra pressure that they may be on in the pandemic. So actually we worked really closely with the community hubs, and they proactively contacted all carers that were potentially known, so that we were very much proactive at the very beginning of the pandemic, reaching out to people and saying, how are you? What support do you need? Do you know that we can access this support for you, that support? And actually being able to sort out some of the community provision, things like food parcels, extra support from the community transport, that kind of provision if that was needed. And I think just people knowing that it was there, we had some really good feedback from that, and we reached out to a lot of carers. So that was one particular example. Debbie, did you want to?
Yeah, so just again focusing on the health inequalities as the North Alliance, so that covers Peterborough, Huntingdon and the Fenland area. We're working with the primary care networks, so we know in Peterborough we've got real issues around coronary heart disease, respiratory, diabetes. So again, the integrated neighbourhood approach is focusing on that cohort of people and how we can support with those earlier interventions, so that actually if we address the health inequalities and the social care inequalities in a coordinated way upstream, that's the areas we're focusing on. So there's a lot of work going on to really identify the health issues that we need to focus on in the city.
Charlotte, did you want to come in there? No? Okay.
Thank you.
Councillor Warren.
4.3.6, the care home support team. In April this year, the council has established a care home support team of social workers for a 2-year period who work alongside managers and staff in care homes and with the CCG quality team to drive up practice and qualities. Why do you think that social workers are best placed to drive up practice and qualities when many have never worked, managed or operated care facilities before?
Okay, so whilst many of our social workers may not have worked in those environments, we've worked very closely with our providers. You know, it's a core function of a social worker to work very closely with our providers, and actually the support that the social workers have provided working alongside our contracts team has been really welcomed by the providers. So it's literally going in there to work with them to understand what the issues they are, what issues they're facing and how we can support them to address some of those issues. So it has been incredibly welcomed by all of the providers we're currently working with. So and they are very experienced, knowledgeable staff that have become part of that team.
Councillor Hamaj.
Hi, looking at page 40, build more care and support around people's homes and the technology-enabled care. That's very good, and I'm really glad to see that. But the issue is, we know that healthcare assistants, I'm a healthcare assistant myself, work for the NHS, but healthcare assistants that work in the community and private sector are obviously on lots of poor wages, national minimum wages, not having much access to training, and we know there's a national retention in keeping those staff. How are we going to encourage staff to actually come and work in these sectors, knowing the wages are poor and bad training, and how are we going to cover these vacancy rates?
Sorry. So we know that actually, the wages of some of our healthcare assistants, as you've said, it's often the minimum wage, but we are working very hard with our providers to look at a living wage as opposed to the national minimum wage. We also support our providers with a really robust training programme for their staff. So so whilst we can manage that quite robustly internally, for example, our reablement staff, our staff that work in day centres, etc., we offer that support to our providers. Now, a lot of the providers have their own training programmes. The bigger providers like Barchester and Bupa, they've got really robust training programmes up and running. But for those smaller providers, the council will support them with that training, and the offer is there for all those for the independent sector market.
Can I just come back on that one? Obviously, healthcare assistants are not seen as, nationally, are not seen as skilled workers, and we are very skilled workers. How are we as a council going to get that across to our residents that care assistants are professionals and are fully skilled workers? And also you talk about the living wage. Is that going to be the real living wage or a living wage? Thank you.
So we would hope it would be a real living wage. As I say, we work with our providers. We look at, the rates that we pay within the, obviously, the council's got finite resource and we do have to balance that. I think, whilst there are, not everybody recognises the value of a healthcare assistant or a care assistant, I think there has been the one positive out of the pandemic, because there has been real recognition of the value of those individuals and what services that are provided. So I think, that's a real positive. And through the council, we are rolling out a number of apprenticeships, and we're again encouraging providers. So there is a career ladder. So you may come in as a care assistant, but actually through various apprenticeships and various different levels of training, you can progress if you want to. Not everybody wants to, but it is making sure that they get the right support, the right training, and that they are treated as a value member of the community, because they absolutely are, and we couldn't deliver what we, our statutory responsibilities and support people without them.
Good.
Thank you. Councillor Kayam.
Oh, sorry, could I just jump in?
Of course.
As well, sorry. I was being quiet then, don't often get accused of that. Just wanted to just add as well that, we just really recognise that, we really recognise as a priority the need to very much promote and increase that understanding in terms of the workforce around it being a career progression pathway, and we're very keen to work with providers and work with the market to support them with that. I just really wanted to say, I think that we recognise it at a local level. Certainly it's recognised at a regional level, and there is work that is happening across the ADAS network around looking at the workforce development opportunities for social care. We were able to do a bit of a recruitment support around the end of last financial year as well. We ran a recruitment campaign which was specifically aimed at increasing particularly, it was a particular focus around sort of personal assistant market, but it was also slightly wider than that as well to take advantage. But we very much did a piece where we did a recruitment to try and very much put that message across and encourage people on a values-based coming into the sector with the right values and understanding that it is very much an opportunity for a career. So we had quite a lot of contacts come out of that. We're still trying to understand how many of those have progressed through to appointments, because we did a recruitment campaign and then worked with providers who we knew had vacancies to pass potential candidates over and support them with that, and how we will hopefully take the learning from that. We will hopefully be able to kind of continue to do some element of that support as we go forward in terms of our plans for workforce.
Thank you for that. But we also know that care workers work in residents' homes, not in care homes.
Yes.
We know that they get 20 minutes with that, potentially 20 minutes with that resident, and then got to travel halfway across the city. They don't get paid any of their travelling time. They don't get paid any of their petrol. So, they may get that little bit of extra wage, but actually by the time they paid the petrol and lost the travelling time, it ends up below a minimum wage.
Yeah.
And that really does need to be looked at. Thank you.
So I agree with you, and again, we don't. So in terms of when we commission care and support from the independent sector, we don't commission 15-minute calls or 20-minute calls. It is based on the assessed need for that individual. So whether that's a 30-minute call or an hour call, and we do expect that the providers ensure that their care staff have got that time to stay with that individual resident in the community, and that actually they are given travel time to get from A to B, because, you know, we've all seen, you know, the programmes that highlight the issues, and I'm not saying that, you know, I'm sure there are issues out there, but we are working really hard to try and manage that with the local sector.
If the care providers, patient-centred care, 30-40 minutes, if the care provider is actually not providing that and doing the complete opposite to what we're doing, will you be removing your services from that provider?
So we work with our providers, so when those issues are highlighted, so often that will be through the call records that we get coming back into the council, or it could be through a formal complaint process. We always address those issues and we will work with the provider. If it was a constant issue, then our contracts team would get involved, but usually when we're made aware, we can work with the provider to ensure that actually what we are commissioning from them, they are delivering and they are supporting their staff.
Thank you. Councillor Cairn.
Thank you, Mr. Chairman. I'm really interested in the full life journey approach. It's point number 4.2.4, in which it's a multidisciplinary approach to enable individuals to become empowered and be positive and make informed choices about their future. My question is, what conversations have taken place with primary care providers? My worries are and concerns are that given the challenges that you've mentioned and future challenges that we will anticipate seeing with COVID, and the big elephant in the room is accessibility to primary care and GP appointments and the lack of GPs, how are we seen to be positive about achieving these outcomes, and have any conversations taken place with the CCG and primary care in regards to the same? Thank you.
So there are ongoing conversations. So we have regular meetings with the CCG, with the acute, with primary care. Most systems, as you know, it's on the news most evenings, are under immense pressure. So there's an awful lot of work going on at the moment between the CCG and primary care to try and understand and trying to work, you know, to ensure that actually the right support, that accessibility is available, so that actually people that need to see their GP have access to their GP. Because if they don't have access to their GP, the default is that they'll go to the local emergency department at the local acute. So there's an awful lot of work going on at the moment. I think we have to acknowledge as well, not only is there a backlog of activity in the acute trusts, I mean, we know about the waiting list, we know how many years that's possibly going to take the acute trusts to reach the point they were at before the pandemic. GP surgeries are facing the same demand or increased demand that's coming through the front door, and also they are also trying to deal with that. And I think, you know, there is a struggle in terms of, you know, we know that GPs have, you know, have left the profession because the demands on them, you know, there are vacancies, etc. And again, the CCG are working very closely with primary care to ensure that we've got a really robust offer locally.
May I come back on that, Mr. Chair? Thank you. My worry is that whilst GPs aren't seeing patients face to face, we have no idea when that's going to be implemented. I'm a GP, and we do have referrals and appointments that are booked in with us from the NHS 111 service. My worry is that when we have such a programme, I worry about the loss of information, or the lack of information, or somebody slipping through the net where their vulnerabilities could be missed inadvertently because we are so focused on making them empowered, when in fact actually we're taking away facilities from them and not concentrating on where the problems actually lie, and that is accessibility. So that is something that I'd like us to take on board to feedback, if okay. Thank you.
Thank you. Councillor Rush.
Thank you, Chair. 4.1.7, COVID has impacted on social care providers due to additional pressures associated with additional demand, people representing with higher levels and workforce impacts. What has been done to assist care providers to mitigate this impact?
So we've worked with providers pretty relentlessly over the period of the pandemic, and that's been an ongoing piece. There's been a range of both financial and practical support that we have put in place and supported providers with to try and help them address some of those issues. Some of that financial support has obviously been distributing of some of the national funding around infection prevention control, so we've tried to ensure we've distributed that as rapidly as possible. In some of the earlier stages, we did put some initial local financial support into the market in Peterborough as well. That was prior to the National Infection Prevention Control funding coming on board. Alongside that, we've provided a lot of support and information to providers, training, information, regular guidance, and really very much continual engagement around the changes that are happening around infection prevention control, the guidance and the implementation of that within their services. And we've worked very, very closely with the CCG and their infection prevention control team to ensure that that support that's been in place, and we've been able to provide that support. I'd also say that we have provided a range of workforce support as well. So I spoke a little bit earlier about the recruitment work that we did, but also we've had a number of providers where things have got really bad, and we have had to look at redeploying a number of staff across the system, both from our health partners and local authority, to actually go into some of those settings at short notice to keep things afloat, and to work with them sort of more medium term to look at their recovery plans to ensure that they've got some resilience going forward. So it's I would say it's been a real range of practical support and some financial support in the mix there as well.
Councillor Ball.
Thank you, Mr. Chairman. If I could take you to page 35, paragraph 4.21, bullet points 1 and 2. It's stated that the system is sometimes impenetrable and you need to make it simpler. I was just wondering if some analysis or modelling can be done around the WHO principle. That is to say, what is causing these complexities and blockages? How can they be resolved? What is the desired outcome? And when can we act and implement the improvements and changes? It seems to me that you know the direction of travel, but you're getting bombarded with the granulation of the issues. And I just wondered if some simple analysis or modelling can be done on the WHO principle, and I think that would benefit you in terms of the strategy in the current context. Because you've had the survey activities and matrices come before us, there's a lot of information there that's already there that needs analysis and some modelling. So that's something that I obviously can't recommend, as I'm only a co-optee, but I put that to my colleagues here. My second question, Mr. Chairman, if I may, takes me to page 41, paragraph 4.41, bullet point 3. I'm wondering, given all the issues that we were talking about around exact living wage, you know, you stand more chance of winning the lottery than getting an actual appointment face-to-face with your GP, whether we should be pushing for greater devolved powers to reach and achieve our recovery plan. Rather than wait for central government funding on an ad hoc basis, should we not be asking for devolved funds and taking initiatives and decision-making down to the absolute first tier level, especially if we're looking at place-based working, we're looking at community hubs and prevention and early intervention modelling and think communities. All of that is devolved down to where the need is most appropriate. So it seems to me the money needs to follow that chain if that modelling is ever to work. Again, I would put that to my colleagues if they want to put that forward as a recommendation. I'm not able to. Thank you.
I wonder, Chair, if I could just respond to those two questions. The suggestion about the WHO principle, will certainly look into that. One thing that we are about to do actually is a sort of review of the kind of customer journey and what's it like from the perspective of people who try and access our services, and what is the customer journey like and how can we simplify it. So that's certainly work that we're about to start and we'll have in train. The question about devolved funds, I mean, in the context of this paper, which is obviously about COVID and adult social care, one of the decisions that the council did make was to we received a number of grants around things like infection control funding for adult social care providers, and actually our approach to that, rather than make a decision within the council about how that would be spent, was to pass it directly on to the independent sector providers and allow them to make the decision about how that funding should best be used, and passport it out to them directly.
Thank you, Charlotte. Councillor Bull.
Can I just come back on that? So is that a theme that's going to continue, Charlotte, where you've got government grants coming and then you're looking at independent providers, you're passporting that money to independent providers? Is that something that's going to be ongoing? I linked that into what our chairman was saying earlier about the private stroke independent sector being brought to the table on issues.
We have a commercial relationship with independent sector providers, so inevitably that means that we look literally at sort of individual care packages and what's needed. But we would always, in a situation where we would, and if put it this way, if we continue to receive grants from central government around support for independent sector providers to manage, for example, things like infection control, then yes, we would continue to follow that principle, because they know what needs to happen, and we wouldn't be able to, estimate that nearly as well as they would. So yes, that would be our approach if those particular kind of grants continue.
I'm grateful. Thank you.
Thank you.
Okay, if nobody else has, I've got a few questions. 4.1.8, you state that fewer people are in care homes. People don't want to go to care homes and need domiciliary care instead, increasing the number of community clients. This appears to be a fairly generalised statement and is contradicted by 4.1.9, which states that the permanent admissions to residential care settings for over 65-year-olds was 30% higher. Allowing choice and independence is absolutely the right thing to do, and I have personal experience of community hubs that are invaluable. But if we're honest, another key driver for this route, for the authority, is that it's cheaper. It only works if the correct domiciliary care package is in place. How are we ensuring that this is the case?
Oh, sorry. Shall I? No, we're fighting now over it. Our response to your first question. So, in terms of 4.1.8, that was actually some of our original assumptions. So, when we were looking at things back in summer last year, near the beginning of the pandemic, we did some modelling largely for our business planning purposes, where we made some assumptions, and one of those assumptions was that we thought less people would potentially go into care homes or choose to go into care homes. What we've actually seen is quite different to that, which is the paragraph, which I haven't written the number down for, but the paragraph later on, which shows that we have seen an increase at the second half of last financial year, and we continue to see that increase as we go into this year. So I think that's just sort of evidences that actually, and that wasn't the only one, there were a number of areas where we made some assumptions based on the fact that we hadn't really been in a situation like this before. We were going into the unknown, but some assumptions around what we thought that might mean in terms of demand and service provision, and actually some of those trends haven't come through as we would have expected them to. So we are seeing that increase. Our initial assumption was wrong, I think, in answer to that question. Did you want to go for part two? Or?
No, I think you've...
I think there was a part two, wasn't there? Was there a question around the community hubs and ensuring...
Yeah, how do we ensure that the correct domiciliary care package is in place? Because I have experience of a number of them breaking down because the appropriate care isn't in place. That's not to say that domiciliary care providers don't provide the appropriate levels of care, because most of them do. But there are a number of cases that I know of personally where domiciliary care packages break down because people aren't trained to the level they need to be to deal with the associated complexities of someone's care.
So in answer to that, I mean, it is difficult because some of those placements at home do break down because people's needs are such that actually their needs would be best met in a nursing home. But actually, if somebody's got capacity, often people do choose to remain in their own home. That's where they want to. That's where they want to live. So we will base that on assessed need. So we will put in as much support as we possibly can. Sometimes that means overnight support as well. But that doesn't necessarily, or you know, a living carer. That is another option we look at. But that doesn't necessarily prevent care and support breaking down. So it is based on everybody, the care and support is based on assessed individual need and the development of a care and support plan to meet the outcomes for that person.
Okay.
Can I just add to that as well? I think as well, it's just recognising that we're on a journey at the moment. So we don't have the answer of what that community model of delivery for domiciliary care will look like in a local neighbourhood level, and that's a piece of work that is very much ongoing, that we will work very closely with providers as well as others, as well as the local residents, around how that could work and model that. Essentially, we're at a point where we are looking at a pilot, our Happy at Home pilot, which will be in East Cambridgeshire. So I recognise that's not Peterborough, but that is being developed at the moment and is very much going to be our initial pilot site. So we're hoping that we can take some learning as quickly as possible from that to see how we can extend that out and then start to work it and take some of that learning into the Peterborough. But I think really it's a journey that we need to go on together.
Okay, thank you. 4.3.6, multidisciplinary team, MDT, delivery based around place to support to providers is coordinated through MDTs wrapped around care homes. These are responsible for ensuring that the right level of wraparound care and support is in place for residents, including primary care, community health, therapy and social care. My question is, what does the provision of this MDT add to the cost of a placement per resident over and above the basic bed price? What is the availability of the team, i.e. how do you determine sufficient resource? And additionally, once these additional costs are applied, how does this compare with specialist organisations who have their own in-house multidisciplinary teams, meaning interventions are given when needed rather than when available?
So in terms of the costing, that is so basically it's what our core offer should be. So it's about primary care supporting those care homes, and the model we're working towards is that you know, each practice or PCN will support a number of care homes, so that actually they've got a point of contact, they know who to speak to if a resident becomes unwell. As opposed to the default that's happened, you know, we'll ring an ambulance, we'll transfer them to hospital. So the whole idea is about primary care and community health services. So not all of our care homes are care homes with nursing. So a lot of our care homes are residential homes, so they are reliant on the community nurses, the district nurses to support them. So the whole idea of wrapping around primary care, community nurses and social care is to actually support those care homes to manage those residents in that environment, rather than, you know, they become unwell or they decondition and they have to be transferred somewhere else. There will be other environments, you know, you've mentioned the specialist providers or care homes with nursing that need far less support than those that haven't got that nursing support in them.
And if I could just add, this is about how the NHS organises itself. This isn't an extra cost in terms of the cost of a placement. So, I mean, I think it's.
But there is an associated cost. Of course, there is.
And what's that?
Well, if you're deploying a multidisciplinary team to be available to care providers who don't provide a multidisciplinary team, then those people are paid wages. Therefore, their services are at a cost. So there is an associated cost to that service.
Yes, I thought the question you asked was what was the additional cost of the placements. So yes, there is a cost in that this is the NHS kind of saying, actually, rather than organise ourselves in that way, we're actually going to try and wrap ourselves around the care home. I think this is something that developed through COVID. It was sort of a national requirement. I think there'll be some review of it and the extent to which it's working. And I think the reality has been that in some cases it's been a very clear sort of multidisciplinary team around an individual home, and in other cases it's, you know, existing arrangements have continued. So I think it does vary quite a lot depending on the availability of resource locally and also the needs of that particular care provider. So I don't think we're necessarily saying it's a panacea or it's working perfectly at the moment, but it's something that quite a lot of our care providers, when they were in the middle of COVID, in the middle of the pandemic, felt was useful because they felt they could sort of have one conversation with the team. But I think in reality it's challenging to do it comprehensively because of some of the challenges around primary care capacity, for example.
Thank you. Councillor Hemraj.
Hi, just a question on the back of Councillor Elsey about the MDT and costs. Obviously there will be additional costs, and my question is, who will be facing these costs? Will it be the families who've placed their loved ones into the homes? Will it be the care homes that would have to face this cost, the council or the NHS? Because someone will be facing these extra costs.
So this is about how the NHS organises itself, and so really I guess it's kind of building on what I said earlier, which is that, you know, if, for example, a decision is made for a district nurse to attend an MDT meeting around a care home rather than do something else, that is obviously a decision that's been made about priorities. So I think it's in the context of what we know are the pressures on the NHS in terms of NHS resources at the moment. And as I say, it's one of those examples of something that developed through COVID, was a national requirement, and we are currently reviewing it and also reviewing a number of other things such as, you know, remote consultations in care homes and that sort of thing. But this is very much something that the CCG is leading on, working with primary care.
Back onto that one. So potentially, if the care homes want these MDTs meetings still to carry on, potentially the care homes or the families would be facing these costs.
No, because this is about NHS services, so it's about how the NHS works out the best way to support a care home. So it wouldn't come as it's, in a sense, it's a cost that's already been paid for through the payment to the NHS. It's really about how the NHS, I guess, has decided to prioritise.
And if the NHS decided to remove this, and the care homes still wanted to have this service?
It's very much a local discussion that individual care homes have with their local GP practice in most cases, and particularly, as Debbie was saying earlier, if we're talking about a residential home, they will have quite a close relationship with their GP practice, and they will discuss with their GP practice the best way to for them to work together, and it varies hugely depending on, you know, the number of GPs available, district nurses available, but also, you know, how many residents are in that home and that sort of thing. So you almost have to look on a case-by-case basis at how that's working on a home basis.
So potentially the costs could be moved to the homes and families in the long term.
I think most care homes would say that they really appreciate they've developed a closer relationship with their local practice as a result of COVID. So I think it wouldn't necessarily be a cost that the care home would have to meet, but it would, as I was saying earlier, it would be a shift in the way in which the NHS has decided to prioritise. But it is very, very varied across Cambridgeshire and Peterborough in terms of what actually happens in practice.
I've just got 2 questions left. Oh, apparently, Debbie, you wanted to come back in?
Well, I was just going to say, because we were focusing on the cost, so GPs have always supported care homes. So for every resident that goes into a care home with or without nursing, those residents will be registered with the GP practice. So they've always supported the care homes, and the community nurses have always supported the residential care homes. It's just about how we have configured ourselves and work closer together so that it's more of a cohesive offer, as opposed to it was very, not hit and miss, but it wasn't always as robust as it could have been. So it's just about really that offer being slightly different to what it used to be.
My first of my last two questions kind of roll on from that. I'm aware that GPs support care centres and homes. What is your interpretation of a multidisciplinary team? Because my interpretation of a full multidisciplinary team is that you have input from neuropsychology, neuropsychiatry, speech and language therapists, occupational therapists, physiotherapists, and so on and so forth. And all I've heard about, and I may be wrong, but all I've heard about is nurses.
So I think the interpretation of a multidisciplinary team is it's open to interpretation. So, if you speak to our community nurses, they will see that actually working with their GP is a multidisciplinary team. So it can be 2 people, it can be 5 people. It depends what that individual requires and what level of support they need. So not everybody needs psychology, not everybody needs physiotherapy. So the multidisciplinary team and offer will be based on what that individual need is.
I understand that, and I'm aware that not everybody needs all of those services, but the terminology is a multidisciplinary team. It's not a multidisciplinary team based on an individual, it's a multidisciplinary team, and that was why I asked the question. My second question is 4.3.6, provider sustainability and quality. The approach to the longer term sustainability of providers is fundamental. We will increase longer term financial commitments with providers through a shift to significantly increasing the number of block purchase beds to spot purchase beds ratio. This will provide more financial security for private providers through guaranteed income. My question is, this is not necessarily correct. Past experiences have shown that through block booking, inappropriate placements have been made, creating serious issues for providers who are not placed to manage presentations, causing disruption, safeguarding issues and damage to premises. What are you doing to ensure that people who are placed, what are you doing to ensure that people are placed on need, not cost? And if someone is placed in the wrong environment, what flexibility have you factored into your cost analysis to either pay in addition to the bed fee for extra care, or to purchase more suitable placements for these people?
So firstly, I just want to come back on the approach. So actually, correct from a double perspective, it's not actually completely right, because we haven't progressed that approach in Peterborough. So it's something that we looked at. We looked at it across the board for both Cambridgeshire and for Peterborough. We have a very different provision and capacity in Peterborough, and we haven't progressed a generic block purchase process in Peterborough, and we largely work on a spot purchase basis. That's because it works well for what we need it to do and for what people need, and it works for providers. At the moment, we have had conversations with providers at various stages to understand if that is something that there would be an appetite for in Peterborough, and the feedback we've had is actually the system we've got at the moment seems to be working better. That's not to say that we won't continue to evolve and look at that, but at the moment we are largely still operating on a spot purchase basis in Peterborough.
Thank you. Councillor Bull.
Thank you, Mr. Chairman. If I could turn to page 40, paragraph 4.3.6, third bullet. When will the Happy at Home pilot start and end? Who will evaluate it and determine full rollout across Cambridgeshire and Peterborough? I'm aware that it's East Cambs that's the pilot, and I understand entirely why that was chosen because of its urban and rural setup. But representing the parishes, you'll understand that I'm, neatly into that niche. So if I could have the answer on that. And who decided we would have this pilot, as well as who will evaluate it and determine the full rollout? So all of that, please. Thank you.
Okay, I'll do my best to answer, and I'm happy to follow up afterwards with some more detail about the Happy at Home pilot, because I know that we do have detailed timelines and information on the consultation process that has been undertaken. In terms of timelines, the work is happening at the moment in terms of starting that co-production process and having those conversations and modelling up what that could look like and how that needs to develop. We're looking at potentially a 2-year pilot, but it will be a full evaluation at the end, but we are looking at the opportunity to do periodic evaluations throughout, because what we recognise is that actually we don't want to wait 2 years, and that before we can look at to roll out in other areas, we want to take the learning as quickly as we can. We are speaking to an independent, I believe it's, I want to say it's one of the universities, but I'm going to have to confirm which one it is because I can't remember off the top of my head. But we are lining up an independent evaluation. But I am more than happy to share a bit more information after this.
Perfect, thank you. I don't know if my colleagues would also be interested in that. Could be an action point.
It will go to everybody, Councillor Bull.
Thank you.
Okay, I think that's the end of the questions. You're probably all relieved to hear. I know, Councillor Bull, you had some recommendations that you would like to put forward for us to make a recommendation. So if I can start with you, and I think, Councillor Kayam, you've got something to say?
No, I just was concurring with what you wanted to say.
Okay, thank you. Councillor Bull, if you could repeat what you wanted as a recommendation slow enough for me to be able to write it down, then I would appreciate it.
It was to do some analysis and modelling around the WHO principle. This is around the strategy and current context on page 35. And it was to look at what is causing the complexities and blockages, how can they be resolved, what is the desired outcome, and when can we act and implement these improvements and changes.
Okay, I can't write that fast.
I can write it out
So
for you, Mr. Chairman.
It's the WHO concept.
It's the WHO principle. What, how, outcome.
What?
It's analysis, the WHO principle.
Yeah.
Can I ask whether the work that I described on the customer journey will help go towards that?
You did say the customer journey would go some way towards that, but it was looking at the fact that the system is sometimes impenetrable and needs to make there's a need to make it simpler. So the customer's journey will definitely help that. But the people supplying the services also need to marry in with the customer's journey, don't they? It's needs and wants as well, isn't it? So the WHO principle fits very neatly into that. You've got people having needs, you've got people wanting to provide, but you don't know where your complexities are. You know you want to simplify. So it's both those things that you have to take into account, the customer journey and overlaid by the services you're providing. That has to be, and you have a lot of that data in the report, to be honest. It's just marrying all of that up together, really.
Oh, sorry. It was Debbie turning me off. She thought I was on accidentally. I just think it'd be really interesting to look at that as well and just overlay it with, I'm conscious that as well as the customer journey piece that Charlotte referred to, there are a couple of other bits and pieces happening as well. So there is a piece of work which our business intelligence teams will be leading on, and we'll be working with the CCG Business Intelligence and Public Health as well, looking at a refresh of the COVID needs assessment, which will be quite wide-ranging actually. That will look at a whole range of the impacts of COVID, including how that flows through to adult social care. And the other area that I'm really cognizant of as well is the work that's going on at the moment around the development of the integrated care partnerships and what were previously the North and South Alliance, and how that models through, particularly with the integrated neighbourhood approach, which is very much that place-based approach. And I believe that there is some external support coming into the system to also work with the ICPs around modelling that up and modelling priorities as well. So I think it'd be really helpful to take that and overlay and see if that sort of fits onto the WHO principles, or if we need to be looking at something else as well.
I think capturing all of that is exactly where we want to be. We've got the data, we just need to analyse it and model it and pick out where the blockages are, where the complexities are, and you'll get those from all the different sources that we've spoken about. And then we'll see what the service is providing and where it's finding the difficulties and the blockages, so that we can make improvements. That's got to be critical to moving it all forward. Thank you. And my other one, Mr. Chairman, was around should we be pushing for greater devolved powers to achieve our recovery plan, rather than just waiting for central government funding on an ad hoc basis. This is us saying to government, you give us the money, we've got the models, we've got the pilots, we know where we want to get to, can you just give us the money up front?
Okay, but that's a question rather than a recommendation.
It could be a recommendation to government that it devolves its money to the actual source of the need.
Charlotte, is that a possibility?
I think the question around pushing for greater devolved powers is probably it's sort of a whole council question. I think that the work that we are doing on sort of community hubs, think communities, moving to a place-based approach, I think all of that is absolutely moving us in that direction. So I think it's for the committee to decide if you want to make a recommendation to central government, but what I would do is give you some assurance that is in line with the principles of how we're the way in which we're working, the way in which we're moving forward is to basically be as local as possible, is probably the way I would describe it.
So in that case, shouldn't we have greater money, given that we have more complexities in this city in terms of its diverseness, in terms of its growth, in terms of access to primary care services?
I think if that's a question about lobbying central government, that probably is something for the committee to make a decision about.
Thank you.
So for the committee, you've got two recommendations that have been put forward by our co-opted members. So first of all, you would need to decide if you wanted to take them as recommendations, and you'd have to have a proposer from the committee and a seconder from the committee, and then obviously to see if you're all in agreement with that. So the first recommendation was about just briefly doing analysis and modelling on the WHO principle to look at what is causing the complexities and blockages and the desired outcome. And the second recommendation is around if the committee would wish to write to central government to look at funding with regard to greater devolved powers and funding locally. I think that's correct. I can get that here. So there are two recommendations, so entirely up to you as a committee if you want to take those recommendations on board, and if so, if there's a proposer and a seconder for each other. So the first recommendation, the analysis and modelling around the WHO principle.
Thank you. Councillor Barkham first.
Thank you, Chair. It was actually, I wanted to put an action point forward, if possible.
Okay.
It was relation to...
Councillor Barkham, can we deal with these two recommendations,
Yes,
and then we can come to your action point? Councillor Kayam first, and then Councillor Rush.
I'm very encouraging of the first recommendation that Co-opty Member Bull has put forward. I think that it is essential to have a look at the blockages and hindrances that we face when looking at the WHO modelling, and I'd be prepared to be a proposer for it.
Thank you.
Thank you.
Councillor Kayam. Do you have anybody who is prepared to second that? Councillor Barkham is prepared to second
very happy to second that.
Okay, so on that recommendation, is the committee in agreement? Yes, that's agreed. Thank you. And the second recommendation, Councillor Rush.
I think on the second recommendation, it should be from the chair of this committee to either write to our MP or straight to government to ask for what the recommendation is for you to write on behalf of this committee.
Thank you, Councillor Rush. I'm happy to do that if we have a proposer and a seconder.
I'm happy to propose, but can I recommend that it's both MPs?
Yeah, I will. Yeah, no, that's fine. Yes, absolutely. Do I have a seconder? Councillor Rush? Is the committee in agreement? Okay, that's agreed. Councillor Barkham.
Thank you, Chair. So it was in relation to section 4.1.4 again on page 32, about the inequalities that have been raised through this exercise. So it was in relation to the getting an update, or if we can somehow monitor what preventative type work is being done and what's being addressed from this. So you'd said, Debbie, earlier that some of these inequalities in the deprived areas in relation to heart disease or diabetes, for example. So it was about, can we as a committee monitor what preventive work is being done about those particular illnesses rather than treating the symptoms of them? And I know when we was on the panel interviewing Giochi about this, she was quite keen to talk about what preventative measures we could take rather than purely treating symptoms. Does that make sense?
It does.
So certainly we can bring a report back. So the work we're doing within the North Alliance with primary care networks, we can certainly bring something back here, I think. Did you want to come in as well and respond to that? Jyoti?
Sure. I mean, there's a huge amount we have been doing and will continue to do to prevent chronic disease, all right the way from our obesity programs to smoking cessation, alcohol harm reduction. So there's a huge amount that we'd be doing in terms of the behavioural risk factors, and then there's the clinical risk factors, and there's something on the forward plan actually around dynamic purchasing, which is about how we can work with primary care to identify clinical risk factors and to then put in programs, either behavioural programs or clinical programs, to address those risks.
Great. So would there be a way to get evidence of these plans that are put together and the work that you're doing to show that rates of these illnesses are either being reduced? Is what you're doing working?
I think because of the year that we've had, I think all of that is
an ongoing plan.
Yeah. Moving forward, yes, absolutely. Through primary care records, we will be able to look at the numbers on disease registers and how well they're managed.
Thank you. Can I just ask the committee then? I'm happy to take Councillor Barkham's recommendation forward, but can I ask if the committee are looking for a briefing note or a full report on this?
Jyoti mentioned that this year is very difficult to monitor some of these things because people haven't been going to the GP to monitor their diabetes pathways. So going forward, there's the data for GP and the preventative data, but we are going to have a very bizarre year of supply, demand and need being very different to normal. So comparing back to 2019-20 is going to look very strange, and we have to understand it. So that's work ongoing, but for tracking, it's not the best year to track against, just because we have to understand the data has to come from somewhere, and it comes from GPs in the main.
Thank you. Jyoti?
I was just going to make the point that actually probably over the last year things have gotten a lot worse. There's not been as many face-to-face interactions with primary care, and so opportunities to identify risk have been much reduced. So, there's not been as many opportunities to take people's blood, to see what their blood sugars are like, or to measure their blood pressure. And so it's almost inevitable that things will get worse because we will have missed opportunities to identify risk.
I think that's fine, and I think the purpose of giving us an update in the future isn't necessarily to try and hit you with a big stick because the results are worse. I think everybody's realistic and will understand that, but it would still be good to see what kind of trend we've got, if there is any trend at all, in terms of the information that's been required. Because once we know where we are, and we can then trying to do something about it. But I still think if we could have something come back, well, probably a briefing note would probably be better than a full report, just to give us a kind of update of where we are.
Okay.
It would be helpful.
Thank you.
Just briefly, so maybe a present position, something to potentially work from, and then discussing what preventive action's been taken, and then reviewing that in the future to see if that's worked.
Yep, that's fine. Thank you, Councillor Barkham. Okay, so we shall move on. So we're moving on to agenda item number 9, which is the review of the 2020-2021 work programme.
Thank you, Chair. This is an item which is brought to the committee at the beginning of each municipal year. It considers items presented to the committee in the past year, which was the former Health Scrutiny Committee, and to make any recommendations on future monitoring of the items that were brought to the committee. It's also for you to determine and approve the draft work programme that was drafted at the annual work programming session. The work programme, I should mention, is not set in stone, and of course will evolve as the year goes on your priorities as they come along. It's also for you to note the recommendations monitoring report, which is attached at Appendix 2, and just consider if further monitoring of the recommendations made during last year should be continued, and we can have a look at that in a moment. It's also for the committee to note the terms of reference for this committee, and as you will see, the committee has changed its name to include adult services this year. So there is that extra service area that the committee are looking at, of which you had 2 reports this evening. So if we move to the recommendation monitoring report in the first instance. So we had an outstanding recommendation from 2018 actually, which was from a report, Primary Care Update. And it was regarding, and you've mentioned it several times tonight, about access to GPs, which obviously is a hot topic this year due to COVID. We are getting a report from the CCG which will update you on this. So my suggestion is, rather than keep this particular recommendation ongoing from 2018, when you get the report, I believe it's in September, coming to the committee, to make future further recommendations or new recommendations on how you feel at that time with regard to GP access, and obviously following on from what they're going to present to you, how you feel about that. So my suggestion is that you close this recommendation off at this point, and then receive the report in September, and then you may wish to make fresh recommendations based on whatever they're going to tell you at the time. So if the committee are happy to do that, we can treat this one as closed.
Are we happy to do that?
Okay, thank you. And then the following 3 recommendations were completed in any event last municipal year. And then we come to one from the 7th of January 2020. The recommendation was for the committee to write to the Health Secretary and the local MPs outlining concerns, again, about GP surgeries. And you'll see there is an update from Dr. Robin. Just before she left, she provided an update on this and saying that the Health Secretary still hadn't responded to the letter, and it's likely that at national government level the work needed nationally on the COVID-19 response has resulted in lack of capacity to respond. Given the time that has elapsed, her recommendation would be that the Health Scrutiny Committee consider whether their concerns about the lack of specificity in the GP contract remain, given that changes have occurred during COVID pandemic, etc. Again, this might be something that you want to follow through after you've received the report in September from the CCG. You may have a fresh approach towards this concern and fresh recommendations at that time. So again, if the committee are happy with just closing that recommendation at this moment in time, and again revisiting your thoughts when you receive the report in September.
We all agreed?
Thank you. And then the final one was one from the Joint Scrutiny Committee meeting, and again that was completed last year. Well, it should be classed as complete, as Dr. Robin did update, saying that obviously with the mass testing now that we have anyway, this sort of it's slightly defunct, this one.
Okay.
So if you're happy with us to
We're
complete
happy to
that
close
one.
that.
Okay, so you can start with some fresh recommendations next year, in particular around the GP offer, if you so wish, when you've had the report through. So really that was the main part of that report. You will have noted your new terms of reference and obviously the draft work programme that was put together at the annual work programming session, which will change and is fluid as you go through the year.
So is everybody happy to adopt that? Yep. Good.
Thank you, Chair.
Okay. Agenda item number 10 is forward plan of executive decisions.
Thank you, Chair. This is a standing item which will be brought to each committee meeting. It's the forward plan of executive decisions, and it's for this committee to note and request further information if required on any items that are relevant to this committee. So if you'd like to have a check through the forward plan, you do receive this fortnightly anyway. It's published on the website fortnightly. This is the current forward plan. So if there are any items where you would like further information on which relate to this committee, if you would speak now. Thank you.
Shall we go through page by page? Page 73. Page 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, and 103, 104, 105, 106, 107, 108, 109, and that's your lot. Okay, so if there's no questions or queries on that, then we move to agenda item number 11, which is the date and time of next meeting.
Would it be possible to ask if we could have a visit to the new urgent care centre, please? We've done a lot of work over the years, so I'd be interested to have a visit, if we could arrange a visit, to see what it looks like and what the flow is. If Pauline, you could do that, please.
Yes, I'll contact the CCG in the hospital and arrange that if everybody's happy. Yeah, thank you.
Thank you, Councillor Rush. So agenda item number 11 is the date of the next meeting, which is the 21st of September at 7 o'clock. Okay, if there's no further business, then I declare the meeting closed. Thank you all for your attendance. Thank you to the officers for your input.